board certified in obstetrics, gynecology, reproductive endocrinology, and infertility. And she is at the Fertility Center of Las Vegas and is the co-author of the IVF Blueprints. We also have with us Dr. Quinn Cattler, who is also board certified in obstetrics, gynecology, reproductive endocrinology, and infertility, and currently serves as lab director at Shady Grove Fertility in Atlanta, Georgia. I am one of the program managers. Like I said, I handle all of our folks in Denver as well as all of our national clients. So we're very excited to have you here today. This is a webinar where we really are hoping that you are also participating using the Q&A function. So if there are any questions that you have that you would like to ask at any point during the webinar, we will have a Q&A period later towards the end of the webinar. So please make sure you're asking your questions, and hopefully we'll have enough time to answer them all. So thank you again for being here, and we're going to go ahead and get started. So we are okay. So we are. JFF is an organization that strives to help people build their families and supporting them along the way. So we do this in 3 different ways. We offer financial assistance to folks that live inside of any of our 11 locations. We have a lot of emotional support services. So that is in the form of our Fertility Buddies program. We offer local and national support groups for anyone in the US, men and women. You do not need to be Jewish to participate in any of our support services. And we also do a lot of educational programming. So we have webinars such as these. We do clinic trainings, sensitivity trainings, and we do webinars, like I said, like this, based on different topics, depending what our clients need. So all of our support and educational services are free of charge. And I am going to go ahead and start our webinar. So we are going to be starting off with just understanding of fertility basics. So I'm going to go ahead and kick it off to both of you. And like I said, please feel free to use the Q&A function at any point. I will start to collect our questions along the way.
Perfect. I'll jump in. Thanks everyone for being here. I'm Dr. Cattler, calling here from Atlanta, Georgia. So nice to see everybody. And yes, just to echo Elisheva, we welcome questions. Really, I think the purpose of this is just to kind of like go over some broad, big picture topics that are helpful when people are starting their fertility journey and just like trying to seek out just like very initial, big picture kind of topics and just foundational level knowledge. We try to keep it to like big picture kind of questions and try to avoid any kind of like very personal questions just because we don't have your medical charts in front of us, but we're happy to try to navigate some kind of larger big picture questions while we're here tonight. So the first thing we're going to be talking about is just understanding fertility basics and when to seek out a fertility evaluation. And let's just start from like very big picture foundational concepts. So typically speaking, the general kind of timeline that we recommend seeking out a fertility evaluation is really age dependent. So and it's really based on female partner age, and we'll talk a little bit about female fertility in a couple minutes. But general recommendation is when you are less than 35, it's 12 months of trying to conceive. And this has some caveats, which we'll touch upon. When you're over 35, it's really a 6-month window. We shorten the timeline just because of the impact of age on fertility outcomes. When you're 40, we actually recommend seeking out evaluation sooner rather than later, typically within 3 months of trying. Things that really don't fall into that category are things that may be impacting that timeline. So if someone has an irregular menstrual cycle or doesn't ovulate regularly, it really doesn't make a whole lot of sense to postpone an evaluation because that is really time wasted. And there's other things that may impact fertility, also may prompt somebody to seek out a fertility consult sooner. Things like underlying endometriosis or other medical conditions that may be impacting their fertility. But the general kind of recommendation is that 6 to 12 month window, depending on your age. Other things that we think about that may be impacting fertility. So questions that I get asked when I see patients that are really within that timeline or sometimes earlier are just like, what are some things that people can think about even before they hit that timeline? Just like what are some things that we can do to naturally optimize our fertility? So a couple things that I think about, and this is by no means comprehensive, but one is just optimizing medical conditions. So I think it's really important when people are early on in their journey, starting to navigate, trying to conceive, seeking out a preconception consult with their OBGYN. This is really helpful for targeting um, underlying medical conditions that may be impacting their fertility, trying to optimize them before they get pregnant, optimizing medications, and just ensuring that the medications you're taking are safe for pregnancy. So really, it's never too early to have that conversation with your OBGYN or even your primary care provider. Other things that you can think about are just healthy lifestyle considerations. We think about optimizing your health from both a fertility standpoint, but also just pregnancy and life standpoint. So really keeping alcohol intake to a minimum. We really try to limit alcohol intake to ideally less than 4 alcoholic beverages in a week. Studies show that excessive alcohol use in the trying to conceive period can prolong the amount of time till pregnancy. Um, Strongly recommend avoiding any inhaled substances. So that includes tobacco, marijuana, vaping. All of these have been shown to impact both male and female fertility outcomes. Sleep hygiene is super important, trying to maintain at least 7 to 8 hours of sleep a night. There's a lot of data that shows the impact of sleep on fertility outcomes. That's hard as we all have stressful lives and jobs, but just trying to prioritize sleep hygiene. Um, and what else? Prenatal vitamin is really important. And just thinking about kind of a comprehensive prenatal vitamin that includes folic acid, vitamin D is recommended for all reproductive age people that are trying to conceive. And there's other things like omega-3 and other CoQ10 supplements that your provider can talk to you about. But really, initiating a prenatal vitamin is critical when you're trying to conceive, actually before you even start trying, to help reduce the risk of birth defects of the fetus's spine. So that's something that the OB will talk to you about even before actively trying to conceive. Um, Other things I like to talk to patients about is just a well-balanced diet. So trying to limit really kind of heavily processed foods, takeout foods, and trying to focus on like high protein, lean meats, and fresh vegetables and fruits, and really just trying to think about diet, not necessarily from the standpoint of like weight optimization, but just having a healthy pregnancy outcome. I think that's kind of like big picture topics from very basic things to think about even prior to seeking out evaluation. But now we'll talk a little bit about what to expect at the first fertility consultation, as well as warning signs and common misconceptions about fertility.
So, at your first visit with the fertility doc, first of all, A plus to you for getting there because that is a huge hurdle in and of itself, just picking up the phone or clicking on the link to set up a consultation. So, A plus for getting that far. But when you get there, be ready to play a game of 20 questions because we are going to play the most personal game of 20 questions you've ever played before. And so we're going to go through all of your medical history with both you and your partner if you have one. That's the basics, things that you already know, like do you have diabetes and high blood pressure? Are you taking any medications? This is a big one where it's really helpful to have the list written down ahead of time because that way you don't have to rely on your memory, which is already stressed about being in the fertility office in the first place. Also, that is also very helpful for us when we say, do you have any medical conditions? And you say no. And then we ask, are you on any medications? And you list off 12 things because it's your blood pressure and your blood sugar and things like that. And so that allows us to pick up some of the things that people forget about or they don't consider because they're really well managed. Then we'll start to get into the more up close and personal set of questions. This is going through, of course, how often are you having a period? How long do they last? Are they painful? By the way, have you ever had gonorrhea or chlamydia? And have you ever had a miscarriage, a termination, a pregnancy before? We really go through all the details of your history, your partner's history, and your family medical history. So it can be really helpful to have all that information written down and lined up, ready to go, so that when you get there, you don't have to devote brain power to it. And you can just kind of look at your list, make sure you didn't forget anything, and away we go. Now, one of the other things that happens at that first visit is starting to get all of the tests set and ready to go. And we're going to talk about the basic diagnostic testing in a few minutes. We won't go too much into detail with that, but we'll start to get you set up for those tests. And that looks different in different clinics. Most of us have coordinators of some sort or assistants who will help you get to those appointments, know what to do and when. But a really helpful question to ask at the end of every appointment you have is, what is my next step? What do I do next? Because that way you're walking out with a very clear set of instructions of, I need to call on the first day of my period to get this ultrasound, or I need to send my partner to the lab to get, poked for labs, whatever it may be. And having that clear idea is really helpful. Oftentimes at the first visit, we try and give you at least a little bit of the financial information that we have. There's two stages of financial stuff, for lack of a better word, that goes on in fertility offices. There's the diagnostic testing, and then there's the treatment. We usually don't have a whole lot of the treatment information up front, some broad strokes, but that's about it. But usually at that first visit, we can help give you an idea of what your insurance does or does not cover and what might be necessary, at least to the best of our ability. Now, even when you go through that appointment, there are some things that people come in thinking. And this can be questions as simple as, should my partner wear boxers or briefs? Because is one or the other going to cause problems? Which the answer is really no, not particularly, unless there's something wildly wrong with either. But there's more common things that people think when they come in. And those misconceptions can be as straightforward as, this will never work. And it can also be the opposite of course, this will work. And we wish that it works every single time. And saying that it's never going to work really underestimates what the technology and the science can do, especially when matched with loving, caring hands of not just a fertility doc, but the whole team, because fertility treatment is really a team sport. Getting pregnant in general is by default a team sport, at least in pairs, but anytime you're bringing in fertility treatment, it is a bigger team sport. And you'll start to meet the whole group of us that are going to help walk you through it. But thinking, oh my gosh, this will never work, or of course this will work, neither of those are very productive. You really have to know what is your story, because in the same way that we wouldn't assume you're like, the last person we talked to, we're going to come up with an individualized plan. We're going to figure out what makes sense for you, not just for the medical conditions, but what are your family desires as well. There's a lot of difference in someone who just wants maybe one kid versus someone who wants three or four or five and maybe has really strong feelings about having family balancing or needing to do genetic testing. There are very different family circumstances for everyone. And we want to make sure that we get that right. And so coming in with a thought of, all right, let me see what my information is really helpful with that. Another common myth that we all hear about is, I'm going to have quadruplets if I do X fertility treatment. And that used to be much more common, certainly, than it is today. Fortunately, particularly with in vitro fertilization, which used to be what everybody would say, oh, if you have IVF, you're going to end up with three, four, five kids all in one fell swoop, and you're going to have a litter. That fortunately is no longer true. We tend to do single embryo transfers. That's got about a 1.5% risk of twins. And the likelihood of triplets or quadruplets is much, much lower than 1%. So it really doesn't happen very often anymore. We see it a little bit more often with Clomid and ovulation induction treatments. Again, we'll go into details about those in a little bit, but you tend to see rates of maybe 5 to 8% in those groups. And so it's really not extremely common, thankfully. Another myth is that every clinic can do everything for everyone. And naturally, that doesn't work and it doesn't fit. And the reason it doesn't fit is because there are different personalities to each clinic and to each doctor and team within the clinic. So if you want someone who's really, absent-minded professor, very academic, that may be very different than the person who's super warm and fuzzy, which may be very different than the person who's super dry and sarcastic and can crack a joke at anything. And none of those styles are better or worse. It's just what works for you. And in the same way, there are some clinics that are really good at doing women who have PMOS, what used to be PCOS, or doing advanced reproductive age, or egg donation, or surrogacy, or particular types of genetic testing. There's all of the different flavors that you can potentially have, as with any medical practice. And so if you go to a clinic and it's not quite right, it's okay to get a second opinion and find where you fit in because we're going through a lot together and you need to be comfortable with us and trust that we are doing the best that we can. And so you need to have a team that matches your general vibe. That's really helpful. All right. So next, we are going to bounce to going through all of the common causes of infertility. Dr. Kettler.
Sounds fabulous. And just to chime in, thank you. That was a great overview. Um, I just want to preface, I think it's really important to think about like that first REI consult as not necessarily committing yourself to some type of involved, arduous treatment. I think a lot of things that I see in my practice is patients, it's really hard to make that initial consultation. And sometimes it takes people months, if not years, to make that consultation. It does not mean you're signing yourself up for some very high-tech treatment like in vitro fertilization. At that initial consult, we spent a lot of time just talking about optimizing natural fertility, dispelling kind of misunderstanding around tracking ovulation, how to time intercourse during a fertile window if it's a heterosexual couple that's trying to conceive, trying to dispel some myths about frequency of intercourse, putting your legs up in the air after intercourse, being in a certain position during intercourse, what lubrications are safe, which ones to avoid. So it's really just information. It's like kind of information overload in some respect, but really dispelling a lot of myths and just trying to help people optimize their natural fertility. And certainly there's always a point in the conversation where we talk about different modalities of treatment to help improve fertility outcomes, things like IUI or IVF, which we'll touch upon. But I think it's really important. I think a lot of people are very fearful of making that initial consult because they feel like they're signing up for some very involved treatment. So I'm glad you touched upon that, and it's really important to know that going into it. Ultimately, we're really just here to help and disprove myths and do some investigating and just offer different treatments and help you understand what treatments are available for you. That being said, let's transition. So we were talking a little bit about common causes of infertility. Let's delve into this. I think a really common misconception is that infertility is like a female-centric disease. That is wildly untrue. Female and male infertility have equal implications. So 1/3 of the time, the infertility is caused by a female factor, 1/3 of the time it's a male factor. And really the remaining about approximately 1/3 is unexplained, which we'll talk about. So when we have a couple that we're evaluating, it's really critical that we evaluate the male factor or the male partner as well. Um, I see on a daily basis male partners that have children from a prior relationship or children at some point they conceived previously. And from my experience, it's quite difficult getting the male partner to commit to an evaluation, but it's a critical piece of this puzzle. And oftentimes we find that that is the cause or there's coexisting causes for both male and female partner. So really in order to effectively and comprehensively evaluate what could be potentially impeding fertility, it's really important to evaluate the male partner. But let's kind of delve into the weeds. So for female factor causes, we really think of the kind of main ingredients that are needed to conceive naturally. So we think of the uterus, we think of the fallopian tubes, and we think of the eggs. So we'll talk about all of these. In terms of evaluating the uterus, there's different modalities and different clinics kind of evaluate the uterus with different types of diagnostic tests. Typically, we do a diagnostic screening pelvic ultrasound, sometimes for patients that are have difficulty with pelvic exams, or sometimes we have patients that have vaginismus or pelvic pain, and we can try to assess the uterine anatomy with an abdominal ultrasound. But we really try to tailor that based on someone's unique situation. But the purpose of evaluating the uterus is just to get an assessment if there's any obvious anatomic changes that could be impeding pregnancy. So we're looking for things like uterine fibroids, characterizing are there fibroids present? How large are they? Where is their what is their location in proximity to the uterine cavity where the pregnancy will grow? We're also looking at the uterus to evaluate for any signs of uterine polyps that may be impacting pregnancy or increasing miscarriage risk. We're also looking at the ovaries and evaluating for any ovarian pathology. Are there cysts on the ovaries? Are there any signs for potential endometriosis that we sometimes can evaluate or assess on an ultrasound? We're also looking for other things like adenomyosis. And this diagnostic ultrasound of the uterus is really helpful for getting a really kind of solid overview of the reproductive health of the uterus. We also are evaluating the fallopian tubes. So at some point during this fertility evaluation, depending on your unique scenario, we typically recommend evaluating the fallopian tubes to evaluate their patency. So trying to see if the fallopian tubes are both open. Different techniques for this. Some clinics use something called a FemView, which is by ultrasound. In my practice, we utilize something called an HSG, a hysterosalpingogram. This is arguably one of like the more uncomfortable tests that we offer, but I always like to prime patients to like expect this going into it. It's very quick. I always recommend medication beforehand. I never want someone to be surprised or alarmed that this is uncomfortable. It's not something that typically requires like anesthesia, but going into it, understanding that it'll cause some cramping for about 10 seconds is very helpful. I find that people that have like a terrible experience or people that aren't primed that this is an uncomfortable test. But it's very, very, very effective at evaluating the health of the fallopian tubes. What this test entails is we place a speculum, gently clean the cervix, and place a small amount of contrast dye inside of the uterus, while at the same time we're taking an X-ray above your pelvis. And you can very clearly see on X-ray if the dye is flowing through the tubes easily, if they're open. We're also evaluating the anatomy of the tubes to see if there's any anatomic changes on the tubes that could also be impacting pregnancy or miscarriage risk. So that's evaluating the tubes. You can also evaluate the tubes a third way. You can evaluate it at the time of a laparoscopy. Different indications for someone to undergo laparoscopy, but sometimes gynecologic surgeons can place dye through the tubes at the time of a laparoscopy. So that's another option. The other evaluation is looking at the ovarian function and the ovarian reserve. So I'll talk about this throughout our conversation tonight, but one of the kind of important facets of female fertility is that women are born with all of their eggs, and our ovarian reserve declines over time. We actually had the most eggs women had the most eggs when they were fetuses inside of their mother's uterus, and that egg reserve actually declines pretty precipitously at birth. But we start to see a more significant change in ovarian reserve or egg count after age 32, but particularly at around age 35 and older. And there's different ways that we can assess for your personal egg reserve. We do this by combination of blood work and actually by ultrasound. Different blood tests, so AMH and FSH are two markers of your egg reserve. And by ultrasound, we can evaluate your ovaries and actually count your follicles on your ovaries. And that's another way that we classify someone as having either a normal egg reserve, an elevated or high egg reserve, or a lower egg reserve. So these are really helpful when we're thinking of fertility treatment, planning treatment, and just getting a baseline assessment of kind of where you are in that curve. Male factor infertility. So the general evaluation for male factor is checking a test called a sperm analysis or semen analysis. This is typically done in our clinic. We do this with home collection. Patients are bringing a sperm sample from home and dropping it off. This was really kind of common at the time of the pandemic, and it's stuck ever since. A lot of men feel very uncomfortable collecting a sperm sample in the office. We still have that option available to male partners, but most people prefer to do this at home. The purpose of the male fertility evaluation by semen analysis is we're looking at a sperm sample under a microscope and we're getting an assessment of different characteristics that are really critical for male fertility outcomes. So we're looking at the volume of ejaculate, the concentration of sperm, the motility of the sperm or the movement of the sperm, as well as the shape of the sperm. And these all are very important in kind of determining is there an impact of the male from the male standpoint in terms of impacting their chance of getting pregnant every month. It's very helpful because oftentimes if there is some issue related to the semen analysis parameters, it initiates an evaluation for male fertility where we are trying to understand what could be the underlying cause. Is it a hormonal issue related to testosterone? Is it an anatomic issue related to a varicocele? There's an evaluation that we do to try to optimize the male sperm parameters if we see any issue related to those numbers. So this semen analysis is very helpful for kind of giving us a comprehensive overview of their fertility. So unexplained infertility, let's talk about that for a minute. Unexplained infertility is a really frustrating diagnosis. It really should be undiagnosed. There's clearly something that's impeding pregnancy. It just means that all of the kind of big picture things that we can test for, uterine evaluation, tubal evaluation, male evaluation, egg count evaluation, all these things are largely normal. It really comes down to there's probably something on a cellular level that we don't have very effective tools for testing. Things that fall into the unexplained infertility category, endometriosis is a really common cause, especially when it's silent. So when patients don't have the classic pain with their periods or kind of persistent pelvic pain or pain with intercourse. So silent endometriosis is thought to contribute to up to 50% of causes of unexplained infertility. So that's very common. There's also things that we just can't test for. So things like egg quality. We have very good tests for egg quantity, but there are no tests for egg quality. And that is thought to be a major driver of infertility as we get older. So these are kind of some of the things we think about. We also think about things like tubal function. We have no tests to evaluate the actual functionality of the tubes. We just know if they're open or they're closed, but there is no test to see how well is that tube actually propelling the sperm to fertilize the egg. There's also things like there could be fertilization issues, something at the level of the egg actually being able to be fertilized by sperm, or an issue related to implantation. So all these things are kind of in the back of our mind when we're thinking of unexplained infertility. The last thing it looks like on this list is thinking about kind of more medically induced causes of infertility. So sometimes patients, or when they're faced with certain medical conditions, can experience infertility as a result of their treatment. So patients that have a cancer diagnosis, oftentimes the chemotherapy and the radiation treatment is gonadotoxic, meaning it can be really detrimental and can have a negative impact on their ovarian function. Oftentimes these treatments can increase the risk of someone going through menopause early. And there's other medical conditions that can also impact fertility and reproductive outcomes, things like lupus, sickle cell disease. So these are all things that, we counsel patients on and evaluate in our clinics. The
One,
next, oh, sorry. Yep,
oh,
Carrie.
go ahead.
No, it's okay.
I was going to say one of the diagnostic tests that we will often get is genetic carrier screening. And forgive me if you were going to jump on that, Dr. Catler, but the genetic carrier screening that we get looks at everybody's got two copies of a gene. If they're both normal, great. They're both abnormal, you have whatever the disease is. If one is good and one is bad, you're fine. Your family's fine. And where it becomes an issue is if each of you carry an abnormal gene, you can pass it down. And then all of a sudden, you've got a 25% chance of having a child affected by a disease that, in general, if we're checking for it, is big, bad, and ugly. And that, as genetic testing gets more and more advanced, we start to see more and more people who either pick up abnormalities on that testing or they've got a family history, let's say of breast cancer. And Maybe their mom and an aunt and that grandma all got breast cancer at an earlier age. That may push them into doing fertility treatment because they need not necessarily the fertility treatment, but they need the genetics evaluation testing that goes with it. And so that's another reason that people come to see us that don't necessarily need the fertility treatment, but that part of diagnostic testing picks up quite a lot. Looking at how we use all of this information. So we're not just ordering all these tests on you to torture you. Although admittedly we are vampires on a first date. That first blood draw is legit, especially for the ladies. We are getting everything in the free world, diabetes, thyroid, anemia, infections, that genetic carrier screening, all of it, plus any specialty tests that are needed in addition to that. So we get this testing, right? We now know about the uterus, the tubes, the ovaries, and the sperm. So now we have to decide what comes next. And in looking at that, you start small and move on from there. And starting small is cheap and easy ovulation induction. This is with medications like clomiphene or letrozole. The brand names for those are Clomid and Femara. And these have been around for a while. They're pills. You take these pills for 5 days early on in your cycle, and then see if you ovulate and time intercourse accordingly. So you get out your trusty ovulation predictor kit sticks or your app with the different type of sticks to pee on and figure out, okay, I'm taking the meds here at this early stage, giving a little time for the egg to develop, and then I'm checking to see if I ovulate on my own with the help of these medications. So this is cheap and easy and allows for you to try at home with less intervention. Time intercourse, we typically tell you to do that the day that you have a positive predictor kit and the day after, for sure, and then some time surrounding that as well. One of the statistics that can be really helpful for people to know when you're trying on your own before you get to the fertility clinic phase of this is that about 50% of pregnancies occur within the first 3 months of trying. About 75 will occur within the first 6 months, and about 80 to 85% will occur within the first year. And so that guides a lot of our treatment for how long do we do these easier, lower key, lower tech interventions. And so doing a timed intercourse cycle with Clomid or letrozole, there's relatively little lift with it in terms of what you do, how much it costs, how much invasiveness it is. And so maybe you do that for 3 to 6 months and see how it goes. Oftentimes people are doing this with their OBGYNs because it's easier to get in, it's more accessible, they already know that doc, and see what happens. Well, if that doesn't work, then that's when we start to up the ante. And we can do things like insemination cycles. And in order to do an insemination cycle, you need to have tubes that are intact. You need to have ovaries that can ovulate with or without help. And you need to have a sufficient sperm count that is at least high enough that we can take advantage of it. So the people who have extremely low sperm counts, inseminations are probably not the treatment for them. What we'll do is we'll use the ovulation induction medications and we'll do an ultrasound early on, check, make sure that everything looks good, start the medications. And then after 5 days, usually around day 10 to 12 or so, we check another ultrasound to make sure that the medication worked because fertility docs are by nature control freaks. If you have one who tells you that they're not, they're probably lying to themselves more than anything because we all have control issues. It's why we do what we do. And we see that we've got all these follicles on the ovaries that are starting to grow. Now, we want you to have at least 1 to 2, maybe 3, depending on your circumstances. By the time you get to 4 and 5, most of us are going to kind of shy back a little bit and go, we want you to have a baby. We don't want you to have a basketball team. And in order to check that, we're looking at the ultrasounds and we see that everything looks good. And we'll have you take your trigger shot. This is the eviction notice for the eggs. Tells them to grow up and get out. And then 2 days later, we will do the insemination. There's two types of inseminations out there. There's the one that is very common that everybody knows about. That's IUI. That's intrauterine insemination. And what that means is that instead of the sperm going right at the top of the vagina at the entrance to the cervix, we go through the cervix and just place it in the middle of the uterus. We let it free. It swims around. We have to hope that it asks for directions. And ideally, it starts to travel down the tube and head towards the egg. And they can have a party together. And then 9 months later, nobody's sleeping at night. When we are doing those types of cycles, they are very helpful, but their overall success rates are not terribly high, usually somewhere in the area of 10 to 15% per month that you try. That's compared to about 20 to maybe 25% if everything is perfect when you first start trying out before you've experienced any difficulties. So it's more helpful than nothing for sure. By the time people get to us, they're usually looking at a 2 to 3% success rate every month. So it's definitely more helpful for that. But going in with the appropriate expectation is important because if you go in thinking, oh, this is 100%, that's a setup for disappointment and being more stressed and frustrated. Whereas if you go in saying, hey, this is higher than what it would be without it, let's see if this works and get it done this way, fantastic. The other type of insemination is ITI. This is intratubal insemination. This is something that you don't see absolutely everywhere. It's a relatively new technology where we've got a special catheter that goes in a little further, and there's an arm that extends out to the opening of the tube, and then pass the sperm through. And general everything else is like an IUI. It just gets the sperm closer to the tubal opening. There's a little balloon that kind of blocks it in there, and it goes forward. And so that is particularly helpful for people who have lower sperm counts. When we are doing an IUI and we get that sperm sample, we can't just take the sperm and put it totally in your uterus. You'd be super cranky at us if we did that. We have to separate it out. So we spin it down and then separate the sperm from the liquid, resuspend it, and place it inside the uterus. So ITIs have a slightly higher success rate. There's really only been one study that's been done about them, and it's an 18 to 26% success rate. I would say that 18 to 20 is probably a more realistic one. So those things are fantastic if they work. But again, you have to go in with the correct expectation of this is helpful, this is not the end all be all. For patients who have either been through all of that and it hasn't worked, or they've got a situation where we have to go to IVF, that's in vitro fertilization. Those situations would include both your tubes are blocked. The sperm count is exceptionally low. There's a genetic condition that we're worried about that we need to test for in advance. Sometimes we'll do this for family planning purposes. Let's say a couple comes to us and she's 37, 38 years old, and they really want to have 3 or 4 kids. Well, I'm not so worried about that first one. I'm a lot more worried about baby number 3 or 4 by the time they're deeper into their 40s and biology is really showing its true colors and making things difficult. And so when we have someone who goes to IVF, there are a couple phases of that. The first is the egg retrieval. 2 weeks of lots of medications, lots of labs, lots of ultrasounds. Our whole teams by the end of this. Like I said, fertility is by default a team sport. With IVF, it is a big team. And once we see you get through those medications, ultrasound visits, lab checks, and we see that the majority of those eggs on your ovary have grown, we'll have you take the trigger shot. Now, the goal of these medications is very different than the Clomid or Letrozole. I really just want 1 or 2 for those types of cycles. For an IVF cycle, we want as many as we can get. If you've got an antral follicle count at the beginning of your cycle that shows there's 18 eggs there, we want to support all 18 to grow. And so that's what those injectable medications do. They mimic the hormones in your brain and they give that support so that instead of having a full table worth of eggs that need to be fed and giving them one measly TV dinner, you just lay out Thanksgiving for everybody. And there's more than enough to eat for everybody. Everybody gets big and strong, and everybody has the opportunity to be the star of the team. We do a retrieval. You're asleep for that, so you're comfortable. Best nap you've ever had. And we'll go take out as many of those eggs as we can get. These were eggs that were going to come out anyway, meaning at the end of that cycle, whether you do IVF, fertility treatment, birth control, whatever, those eggs were going to be gone. So our goal is to turn them into a more usable function than just letting them die on their own so that we can play a numbers game. Many of these eggs are going to be abnormal. That is expected. That is human biology. As you get older, particularly crossing the age of 40, a very large percentage of them are abnormal. It's why we go for so many, so that we can play the numbers games. Can you tell I live in Vegas? And we help to get them inseminated, so combine them with the sperm. And then over the next week, they're going to grow into embryos. And if they need extra genetic testing, we'll do that. And see what kind of results we get from that cycle. At this point in time, most people are doing frozen embryo transfers rather than fresh transfers. And the reason for that is that in general, it solves an awful lot of problems. And what it allows us to do is instead of trying to cram the best of the ovaries with the best of the uterus in 1 2 week period, you separate it out. You get the best of the ovaries, the uterus does whatever it wants. You get the best of the uterus, the ovaries do whatever they want, and you can maximize both because compromise is great in marriage. It is not good in an embryology lab. You want to maximize everything you can get in every way that you can get. So you maximize one, you maximize the other. We know that as you're going through this, the numbers are going to decrease. And so you may have this many eggs, this many come out, are mature, fertilize, grow into embryos, pass genetic testing if you're doing it, and become a baby. That's why we want as many as possible. And it's why for people who maybe have lower egg counts, we have to do more than one egg retrieval. The goal is always one cycle and done, but we work with what we are given. Once we get the embryos, we then plan for an embryo transfer and prepare your uterus with medications. This is usually a bit easier than the retrieval part of this. And transfer typically one embryo at a time. And then we see what happens. Success rates for IVF tend to be much higher for someone who's under the age of 35, usually upwards of 60 to 70%. And oftentimes you will be able to get more than one embryo. The goal is to get as many embryos as we can to freeze them so that you have multiple attempts just from one egg retrieval cycle. Sometimes that works beautifully and sometimes it doesn't. But the team goes through that whole process with you in an effort to get you all the way from beginning to end. Now, there's genetic testing that we can do in there called PGTA. That looks at do we have 46 chromosomes, no more, no less. That'll pick up things like Down syndrome. There's no testing out there that we know of that can pick up stuff like autism and schizophrenia and other abnormalities, atypical disorders like that. But the testing's getting better all the time, so who knows what 5 years from now will bring. We will also often have people who, when they come into us, there is a distinct need that we know about from the beginning. For example, a single woman comes in, a same-sex female couple, a same-sex male couple, a single man, any variety from LGBTQIA plus that needs a little bit of extra help because they don't happen to have sperm, they don't happen to have eggs or a uterus with the ability to carry. Whatever it may be, we can help work with you to fill that need. And that can be with egg donation, sperm donation, gestational carriers. There's a whole world of technology that can help us get you to the family that you want. And so that's those are the treatment processes in a nutshell. What questions do you all have? And Quinn, do you have anything to add? Dr. Cattler, do you have anything to add to that very condensed version of what we do?
No, that was incredible. Um, I don't know about y'all, but I was like laughing up a storm. You are so funny. Um, your patients are lucky to have you because the way that you describe things is very like logical. Anyway, great overview. The only other things I was thinking about, which fall into this category, are just like the emotional and financial considerations.
Mm,
The emotional piece of this journey is very real for all patients. Um, Anybody that is going through fertility treatment, we have to keep in mind that oftentimes they've been trying for a very long time prior to seeing us. So they're already coming into under our care with an emotional burden, and you add all these shots and the ultrasounds and visits to our office, and it just the emotional burden is like very significant. So I think it's really important, and I really encourage all people to really focus on really prioritizing mental health throughout this. The fertility journey is very much a marathon. It's like never, ever, ever a sprint. I wish more than anything that every patient was successful on their first attempt, but it's really, truly like uncommon for that to happen. And there are hurdles, and schedules change, and sometimes patients have delays to their treatment cycles for a number of reasons. And the kind of somebody that's gone through fertility treatment myself, like the timeline shifting and like the very much like it's always like a long period of time for most people. It's just like very helpful going into it, knowing that that's like the reality and that's okay and that's very normal, but also just prioritizing ways to um, focus on stabilizing and supporting your mental health. And whether that's through acupuncture or meditation or Reiki or going for walks after work with your partner or with a friend, finding a great fertility therapist. Most cities have fertility therapists that are really meant to just support couples and individuals as they're going through infertility treatment and working on building their family. JFF has great emotional resources, as Elisheva mentioned. These are free and really non denominational. It's not just for Jewish patients or Jewish couples. It's available to everybody. They have support groups that are free, virtual support groups, a buddy program where they'll match you with somebody that has gone through fertility treatment as just like somebody else that you can text or call, probably not in the middle of the night, but at appropriate hours, just to kind of have somebody that has gone through this process and come out the other side successful. And the other piece to this is financial considerations. So fertility treatment, the great thing is that as this is becoming much more kind of discussed and open and talked about on social media and podcasts. There's really like an increased attention for increased coverage for fertility treatment. There's been such a significant change over the past decade, whereas when I first started in this field, it was like very uncommon for insurances to cover fertility treatment. But nowadays, like roughly half of patients have some type of fertility treatment coverage. But there's also other ways that we support patients financially, whether it's through steering them towards grants that are available to apply to. Jewish Fertility Foundation also provides grants for fertility treatment. So it is an important part of this kind of conversation. It's outside of the medical and the psychological, the financial piece is like pretty significant for most couples, understandably. So we really spend time trying to help people navigate the financial journey too.
Thank you both. This was so thorough. I'm like having done this for as long as I've been doing it. It's like it's still. I learned I had never actually heard of ITI. So, Dr. Bedian, thank you for. I did not know about that. So, we did have a question that came in. The question is, what is the general time frame from deciding to start an IVF cycle to confirmation of pregnancy, assuming all goes well? One of you want to take that?
I think this is going to vary from clinic to clinic. For us, I would say it's ballpark 3 menstrual cycles. My world operates in menstrual cycles. And so the first one is getting the eggs out and creating the embryos. The second one, most people are getting PGTA, so we're waiting for those results. And then we typically do a hysteroscopy to confirm the uterus looks good. And then the third is a transfer cycle. So I would say that's pretty typical. You can potentially cut out that middle month. Or if you were truly doing a fresh cycle, you can be one and done. But I would say the majority of the time, the fresh cycle is not really usually in your best interest. Um, when you add in from the very first visit to a fertility doc's office, at that point, you usually need to add on an extra, I would say at least 2 menstrual cycles, one to get the testing done, and then the other to just get your ducks in a row. Talk to your doc, talk to your partner, think about what you want, marinate on it, and then make decisions and start to pull together medications and timing and all the rest of it. You also don't have to do it back to back to back. So if you're doing IVF and you say, all right, I am going to do, the first part in June, and then I've got an amazing vacation planned in July, and so I'm going to come back in August and keep going. That's fantastic. And oftentimes it really works well for patients because they can get a breather in the midst of it and not be quite so overwhelmed.
Mhm. I love that. I do have one more question, but I just wanted to, first of all, thank you both for being here. Both doctors are actually on our medical advisory council that help us in so many different ways at JFF. And Dr. Kettler did talk about some of the resources that we do have available. Please feel free to go to our website, jewishfertilityfoundation.org. We have so many resources. Our Fertility Buddies program, like you said, matches someone who's actively going through a journey with a veteran, someone who has been through a journey, has had success, is now on their side. And it's really just a peer support program to hold your hand, be there to walk you through it, even if it's from across the country. It's a wonderful resource. We have, even just nationally, we have 8 to 9 support groups per month that we offer that are very topic specific, from genetic factors to surrogacy, LGBTQ plus, but East Coast, West Coast, and fertility. So we have so many different services that we offer. Please take advantage of them. So one question I did want to end with, I think, so we can, maybe both of you can answer this, is after everything that was discussed tonight, what is one thing that you would like someone that is listening to walk away from knowing about their fertility or just about their journey?
I'll jump in. Oh my gosh, there's so many things I think fall into that category, but I will say, um, honestly, just by showing up for this webinar, like the biggest thing is like just advocating for yourself and taking the time to just like put in put in the effort to like actually understand your fertility. And I think you're doing the right thing by just showing up, getting different people's perspectives, understanding different things that may be contributing to fertility outcomes in the future. Um, I'm a very strong proponent that knowledge is power. And I think that just even seeking out a fertility consultation just to kind of get an overall assessment and understand your baseline fertility, whether or not that leads to some type of medical intervention is like a very personal decision. But really, just kudos to y'all for showing up. It really means a lot.
I would second all of that. And then I would add, you are not alone and you are not broken. And both of those things are incredibly helpful to write down and put on a sticky note and put it on your bathroom mirror so that every time you brush your teeth, you see it, or across from the toilet. So every time you pee, you see it. Like you can't ignore that information because you are very much not alone in this. We all have clinics that are full of not just the docs, but there's the nurses and the coordinators and the ultrasonographers and the medical assistants and the front desk staff and the phlebotomists. And you would be amazed at how invested we all get in people's journeys. And that's just at the clinic. That doesn't even count the support groups that are out there, Facebook, Instagram, TikTok. Not that I'm ever endorsing Dr. TikTok, but all of those places, there are resources. You are not alone, and you're not broken either. Most people don't think twice. Oh, they're given a diagnosis of high blood pressure. Well, crap. Okay, that's just a part of being human. Well, so unfortunately is infertility. It exists in all species, and if you happen to have it, it really sucks, but keep on going, and you're not alone. You're not broken. We got this. Just keep going.
Yeah, and to your point, I appreciate you saying that. That's a really important kind of take-home message, and just validating this is just so common. Like the most recent studies out there show that this affects 1 in 6 couples, and that prevalence just gets more common as we get older. So there are family members, friends, colleagues. There are people out there that are many, many, many people that are experiencing the same disease. And I think it's really important to understand or think about infertility as like a medical problem, that there's medical solutions to help, and not necessarily that there's something wrong with either male or female's body. There's no one, we're not trying to assign blame or fault. And sometimes people can fall into that trap of trying to blame their partner. But really, ultimately, we think of infertility as we think of any other medical condition that has treatments that are really meant to help improve the overall disease outcome. Um, but yeah, thanks, Carrie. That was really helpful.
Wow, that was beautiful. I kind of want to put it on my having experienced my infertility journey a while ago. It's I wish someone would have told me that. And we have so many people that come to us and feel like just saying that over and over again because it really is true. And what both of you do and all the REIs. It's really, you provide just that glimmer of hope for people. So and for all of you that are attending, we also have resources for family members and your support systems and friends. If you need anything, we are here for you. Please don't hesitate to reach out to anyone at the Jewish Fertility Foundation. We are here for you. Dr. Beatty and Dr. Cattler, thank you so much for being here. We are so grateful to both of you for tonight, your time on our council, for being our cheerleaders, to allow us to do what we do. So thank you both so much. If there's any other questions after tonight, please feel free to reach out to me. You've probably gotten emails from me, so elisheva@jewishfertilityfoundation.org. I'd be happy to answer any questions or put you in touch with either of these two doctors. So please don't hesitate to reach out. And I hope everyone has a wonderful evening. Thank you so much for coming. Bye-bye.